Hey. We'll be talking about tennis elbow etiologies or common extensor tendinoses etiologies. So we're not looking at tendinitis, we're not looking at direct trauma or obvious unfamiliar overuse. These are tendinoses that are caused in part by use, but mostly because there's a predisposition to the common extensor tendon to degenerate and to become symptomatic. From experience, I would say that many people have preclinical tennis elbow because when you palpate the tendon, it's a good deal more tender than the other side is. So it just hasn't got that final step where it becomes a symptomatic problem for the patient. But it does indicate that there are predispositions as etiologies or contributors to the problem. It's often what we perceive as overuse that is the trigger to the symptoms coming on. All right, before we get started on this, let's have a look at the questions I asked previously on straight leg raise testing and to a lesser extent upper limb tension testing. Question one, if the straight leg raise demonstrates positive with somatic pain, discuss the possible causes. Now, strictly speaking, if all I do is a straight leg raise, then this could be positive for any number of reasons. We're assuming that pain is your positive. If pain and limitation is your positive, actually the same thing applies. So if the straight leg raise demonstrates positive with somatic pain, the tissue that's causing it is a somatic tissue. So this could be the hamstrings, it could be the glutes, it could be the hip joint, it could be the sacroiliac joint, it could be the lumbar spine. So all of these things are possible. Now, if we're looking at straight leg raising as a neuromeningeal test, then we lose a whole bunch of this. Because now what we're going to say is a straight leg raise test is when all of this is straight, but if you tighten it up or slacken it off by moving any of the joints involved, it changes the result. So this now is a constant length phenomenon, which basically tests any tissue running over two or more joints, where one or more of those joints or that tissue is involved in producing the pain. So, for example, if I did a straight leg raise and it was painful, when I did straight leg raise, then flex the knee and the pain in the hamstrings eased off, then, or the pain in the posterior thigh eased off, then I would be thinking that this is quite possibly a hamstring tear rather than a neuromeningeal problem. At the same time, if the buttock pain that went there from the gluteal tear stayed, I'd be thinking this is almost certainly not neuromeningeal and may well be a buttock tear. So if we're talking about neuromeningeal problems where the straight leg raise can be varied by changing the tension of that tissue, then the neuromeninges is one of them. In fact, it's the major one. So the Dura, probably the dural sleeve. Now remember though that you have adjunct tests that also test this. Dorsiflexion of the knee, flexion of the neck, but what's never mentioned actually is slacking the whole thing off by bending the knee. But these are all adjunctive tests. So if these are positive, then almost certainly you have a neuromeningeal problem. Providing that the limitation is not right at the end of range, because now you may be just looking at a stretch response through that whole posterior tissue, and the patient is misinterpreted its pain. So you need a fair amount of asymmetrical limitation. Number two, if one of the causes are adhesions, how would you clinically prove it? Well enough to start stretching. This is important because stretching a nerve or the dural extent of the nerve when it's actually being compressed by something doesn't do anybody any favors. This is how you really flare things up. And you see this all the time in the upper limb tension test, where these are very commonly stretched, whereas straight leg raise is rarely stretched. And it's really interesting why the same criteria are not applied to both. So how do you clinically prove it? Well, you look at the alternatives to this being adhesions. Disc herniation. The patient has the signs and symptoms of disc herniation, for God's sake, don't stretch it. If the patient is unable to move in directions other than flexion, which simulate the straight leg raise, so extension or side bending, then don't stretch it. There's something else going there that you don't understand. So really, for these to be dural adhesions, you need a couple of things. One, you need a history of trauma that has caused those adhesions. The most common cause of this is a disc herniation. But I suppose fractures may do it, but something fairly massive, not disc herniation, it's going to be a fairly massive trauma. The other thing is only straight leg raising or trunk flexion are positive, and nothing else. Now this may be somatic, or it may be dura pain. The dura may only be involved, or the neura may be involved. And then you can start thinking of stretching, but when you do so, do it carefully. Number 3, if the upper limb tension test for, say, the ulnar nerve is positive with somatic pain, what are the possible causes given the anatomy of the dural sleeve? Well, as we said, the dural sleeve is attached to the transverse processes. When you move the arm, the dura doesn't move, the nerve moves through the dura. So the dura will be stretched by moving the neck, so neck flexion, contralateral side bending, but none of the other stuff will move the dura. Won't increase the tension because it can't. So when you have somatic pain with these tests, you actually start thinking of something more other than dura problems. Now, if you get neurological symptoms, then you have neural problems. That's fairly straightforward. But if it's somatic pain, then you're hard pressed to come up with a reason for it. And sometimes this is just the patient tone changes, and this happens with joint problems and everything else. So this may just be tone changes throughout the limb, and you have to look at some of these tests, and some of these are really primitive reflexes that you're actually stretching it into. So think other tissue before you start thinking dura for the positive test here. Number 4, how would you differentiate straight leg raise from dural adhesions from one caused by a compression of the dura by a disc herniation? They look totally different. We go back to question 2. You're looking for massive pains, limitation of movements in all directions, and so on. What may a cross-leg straight leg raise signify? Well, one thing is it's more sensitive, and it's more it's less sensitive, sorry, and it's more specific for dural compression or neural compression. Come to that. The fact you're lifting one leg up and the pain's going down the other leg suggests that there may be a problem with the positioning of the disc herniation. So this may be an axillary lesion because now doing the straight leg raise on one side is actually pulling the dura over to the other side. So this is possibly what's happening, but what you can say is more specific for a disc herniation. Number 6, if a patient has severe signs of lumbar disc herniation and a straight leg raise of 10 degrees, how would you interpret it given the biomechanics of the straight leg raise and points where it claims that the positive should lie within 30 degrees and not 0 to 30 degrees and not out of it, because this is where the crimp is being taken up before 30 degrees, so it can't lay below it. Those biomechanical tests where they measured 30 degrees, 60 degrees, 90 degrees being supposedly dural, the start of dural problems, the end of dural problems, and the beginning of joint problems. The problem with that, it was done on cadavers. In live patients, the dura can be tractioned up. So you'll see people with such a bad disc herniation, they cannot lay on their back and put their knee down on the bed. So these are minus n degrees. So just because it's below 30, it doesn't mean to say it's not a neuromeningeal response. And in fact, you're going to be hard pressed to think of anything else it might be. So these would be my answers to those questions. I'm hoping that you discuss this on the Zoom session. If you didn't, you have to pick the bones out of this, and you've missed the opportunity to have a really good discussion on this subject. You can always bring it back up again, though. Well, let's have a look at these etiologies in general rather than specific. So the things that can cause a common extensive tendinosis. Neurological causes. So this can either be frank loss of electrical conduction down the nerve, so a radiculopathy or a neuropathy in terms of the stuff that a neurologist would recognize. Or this can be axoplasmic flow loss, which will have no other neurological signs or symptoms of the neuropathy, and may actually be multi-crushed rather than coming from a single site. So this can produce false output weakness via the synaptic failure, or structural weakness because of slow flow problems and causing trophic malnutrition. It can be mechanical, simple overuse, internal overuse. Now I'm talking about, not what we consider normally as overuse. So an abducted ulnar, for example, or an extension hypomobility in the wrist will all cause these muscles to overuse. This is one model, the one model I'm using. So because you can't get full range extension, your proprioception drops because of that, and so you require more from those muscles and producing that overuse. The other way to think about this is length tension relationship screw ups, and I've never found anybody who can adequately explain that to me in terms of the elbow. An abducted ulnar isn't going to change the length of the muscle very much, so it won't change the tension in the muscle very much. I think the model where you're looking at it as overuse, internal overuse, it's clearer and more simple. And as I say, models don't have to be truthful, they just have to be helpful, both in envisaging the problem and in producing an intervention. Or this can be neurophysiological. The dysfunction in the elbow or the wrist can produce reflex inhibition, which weakens the muscle and makes it vulnerable to degenerative changes. Same for the tendon, obviously. And also nociceptive dysfunctions can produce segmental facilitation that can produce the same effect. The changes in tone and the hypertonus or hypotonus, I think, play some role in this, but probably not a massive role. It's probably just the weakness that's causing the biggest problem of all. So before we get into this fairly complicated slide, just a reminder, segmental facilitation is identified by hypertonicity, non-fatigable weakness, and less obviously the scratch test along the spine, plus trophodema, orange peel skin, and so on. But the main ones initially will be the weakness. So your screening test for it is actually a strength test to see if there is weakness there, and then deciding whether it's fatigable, non-fatigable, or breaking. And from there you go to looking at tone, and then the scratch test, and so on. Reflex inhibition, and that's distributed segmentally, not because the dysfunction is necessarily in the spinal segment. The signs and symptoms are distributed segmentally, and the thing that's causing it can occur anywhere within the tissues supplied by that segment. Reflex inhibition, on the other hand, is local. It consists of breaking weakness and hypotonicity, and it's generally patterned, and it looks like a PNF pattern. So these are the things we're going to be looking for when I say segmental facilitation. I mean that you've identified segmental facilitation by those things. Now, from this slide, we come in with a diagnosis of common extensive tendinosis. This isn't a hypothesis, it's not tentative, this is our diagnosis going in. Now, one of the things you can do to decide how much segmental facilitation may be playing a role in this without looking for segmental facilitation per se is retest wrist extension. But now do it with the head in different positions. You put it in quadrant positions, flexion, quadrant, extension, quadrant, and so on, and then keep retesting. If there is a major change in the amount of pain that's occurring in the wrist or in the elbow when you're doing the resisted test, then you know that segmental facilitation is playing a significant role in this. Because some of that pain is coming from segmental facilitation. That's all it can be when you're changing the neck and getting these changes. If the pain disappears entirely, there is no clinical common extensive tendinosis there. It's entirely segmental facilitation that's given the symptoms. It doesn't mean to say there isn't an incipient tendinosis there. You can get these, you find people all the time with asymmetrical tenderness on the common extensor tendons and other tendons, but they don't have any symptoms from it. And when you look at them as if they were symptomatic, you find all the stuff that you would expect to find. So this is a quick test to see how much segmental facilitation may be playing a role in this. Okay, now you can either look at from the diagnosis, you can either look at the etiologies from the perspective of an intra-unit issue or an extra-unit issue. Now, there's pros and cons with both. The pros with looking intra-issue is that you're there. You're in the elbow and it's easy enough to go. So you can look at the elbow and you can look at the wrist for etiologies. The cons with doing that is disturbing the proprioception. When you do that, particularly if you repeat tests frequently, then you can lessen the neurophysiological effects. So when it comes to looking more globally, or at least, globally, for etiologies, then they may have been diminished by what you've done in looking at the elbow. So there's pros and cons. Probably the purest way of doing this is look for segmental facilitation first. So that's what we'll do. So we're going to go on this chart downwards, vertically downwards, and we're going to look at extra unit etiologies, and we strength test C6 and 7 muscles. Now, when you do this, you're not going to hit everything. For example, reflex inhibition is probably not going to show up very well when you do your routine strength tests. These often need to be taken to the end of range and then an eccentric force through them. So they may not show up. If they do, fine, but they may not. So there's our 3 possibilities for positive, assuming they are positive. If they're negative, then with the exception of the braking weakness, which you will have to retest when you look locally, you can say that there isn't segmental facilitation or a neurological etiology here. So if this is fatigable weakness, you know that you're looking for a neuropathic issue. Now, the neuropathic issue could be a soft or a hard one. The soft one being AXT compromise, which is not electrical. This is loss of protein flow. So we're going to look for fatigable weakness and no other signs. We don't expect to see any other neuropathic signs there. No sensory loss, no hypotonus, no hyporeflex here. Just the weakness. And it recovers pretty quickly when you stop the testing, leave it for a few seconds, then you can retest, it comes back pretty strong. Otherwise, you're going to see electrical conduction loss with fatigable weakness, which would suggest either a radiculopathy or a neuropathy, depending on the distribution. Now, all of this can, of course, be a single crush or a multi-crush, and there you're going to have to find out which it is by working your way through that nerve system and find out where the weakness starts and where it ends, actually. So, if we have non-fatigable weakness, we're probably looking at segmental facilitation. You look for all the signs of segmental facilitation. Now, if that's what you find, you go vertically upwards and you screen the other joints for nociception. Now, you really can't screen the dysfunctional joint, but you don't know which that is, whether it's the elbow or whether it's the wrist. So you screen all the joints and see which one is nociceptive or which ones are nociceptive, and then you're going to look at the biomechanical dysfunction underlying that nociception and decide if that biomechanical dysfunction can contribute or cause the common extensive tendinosis. If it really makes no sense that it could cause this, you basically ignore it. Now, if, on the other hand, you find braking weakness, which is not likely given the way we're testing this, then you know you're dealing with reflex inhibition. Now, if you're finding that in joints other than the elbow or the wrist, it really doesn't play a role in the tennis elbow. It may play a role in that joint being nociceptive and causing the segmental facilitation, but it's not a direct cause of the tennis elbow. And we'll look more at these tertiary and quaternary etiologies in another presentation. So this is looking for more global issues, or at least quadrant issues, segmental facilitation. If we go into the local unit etiologies, then we're going to be doing quadrant testing. So we quadrant test the elbow, we quadrant test the wrist. Now, if those quadrant tests are positive, we go horizontal from there, and we do a biomechanical exam of the elbow and the wrist. And if we find an abducted ulnar or a carpal flexion subluxation, so basically in both cases the wrist can't extend either because of the abductor or the carpal subluxation, then this becomes this could easily just be a direct mechanical problem in the form of overuse. The muscles working too hard against the resistance of the extension of the wrist and then breaking down. Or again, it could be reflex inhibition, or it could be segmental facilitation. Now, these may be causes, or more likely, if you find an abducted ulna, these are contributors. It's not helping matters. In which case, with segmental facilitation, you go back through the screening test for nociception up and see if that dysfunction fits. Now, we know it's an abducted ulna if it's a wrist or a carpal subluxation that's limited in extension. So in this case, you know they're going to fit. If, on the other hand, when you do the biomechanical exam of the elbow or the wrist, there's other dysfunctions there that don't fit properly, then the only way they can cause a problem really is either assuming that it's not in the same pattern, we're going to be looking at reflex inhibition. It could be segmental facilitation again, in which case you go through that same screen. But more likely it's the reflex inhibition that's going to be the real issue. If the quadrant tests were negative, then what you're left with is segmental facilitation, and that is probably coming from the tennis elbow, but it may not be. So again, you go through all the screening tests. If you haven't already done it previously, you go through the nociception screening tests and you do the same thing again. But more likely, if you're following the pattern I suggested, that is look extra unit, that is quadrant test it, and they're all negative for nociceptive problems. Then when you get into this area where you've got the quadrant tests are basically negative, you've still got segmental facilitation, then it's probably that pain is coming probably from the elbow or the wrist. So, or that nociception comes from the elbow or the wrist. And so once you get rid of the problem, the mechanical problem, the nociception should go away. So there's no need to worry too much about it. So we'll be doing a lot more of these discussions on etiology, a lot more. This is the bulk of the rest of the program. So a lot of detailed clinical reasoning, and you're not going to get enough of this by any means, but we're going to hit you with this over and over again. So enjoy.